difficult to get reliable data on this? Why do they disagree all the time?
There's a couple of reasons. One is with the Miller et al. Study, one of the criticisms was the mammograms took place in the 80s when the equipment wasn't as precise as today. So that meant if it's less precise, it's less good at detecting early stage cancers where there's a greater benefit for detecting them early. The other thing that is happening, so when people hear you shouldn't get mammograms, they think it's the radiation that's the danger. That's actually not true. What physicians view as the danger is that it's really, they can't tell on mammograms now whether cancer will spread or not. So you need to go in for additional tests. You need to get a needle biopsy where they remove tissue with the needle, which is very invasive and also very emotionally draining. So what they're saying is you get all these women who get a positive on the test and then go in for all this treatment and it turns out it wasn't necessary. So that's why currently they still recommend mammograms, especially for women with a family history of breast cancer. Personally, I think, and when I was at a conference a couple years back, what's going to happen is they'll develop more precise mammograms, like 3D mammograms, where it will be a lot easier to detect the lumps while they're small and there's more beneficial treatment. So just quickly, cervical and colorectal cancer screening are still recommended. Even for women, if you get the HPV vaccination, you should still get regular pap smears. With colorectal cancer screening in the US, they recommend colonoscopy. I think one of the main reasons why is a lot of HMOs in the States will pay for colonoscopies. In Canada, with the public health care system, it's a lot more expensive, so instead they recommend the fecal occult blood test. It's also, the occult test is also less invasive, so they think there's a higher likelihood of people getting screened. Even though currently the screening is very low, and most provinces don't have a systematic population-based screening program in place.
But is that colonoscopy recommended to young people who have problems like constipation and what else? Ulcers?
Yeah, if you're like systematic for something, or like if you have colitis, you're at higher risk of colorectal cancer, so they recommend the colonoscopies. Or if you've got a family history of colon cancer. It's only in people who have no history of colon cancer in their families and have no digestive issues. In that case, that you can start with the fecal occult blood test because it's cheaper and less invasive.
Fecal and blood test.
Fecal blood test, so it takes a stool sample and looks for blood in the stool, which is an early indication that someone might have an early cancer. So screening mammography disparities vary by ethnicity, SES, and access to healthcare providers. And researchers, even though most research has looked at screening mammography, these factors also produce disparities in cervical and colorectal cancer screening. So among ethnicity, whites and African Americans generally have higher rates. Hispanics and American Indians generally have lower rates. With SES, as you might expect, higher income and higher education are more likely to get screened. Access to health care is another factor. So in countries with public health care insurance, having health insurance is that you're more likely to get screened, and also having a family doctor, you're more likely to get screened. One reason for the family doctor is often people will get screened when they see a family doctor and the family doctor recommends it. And then family situation. So older women are more likely to get screened, and married women are more likely to get screened. And with the family situation, this is really, they've only examined this in screening mammography, not the other forms of screening. So there's also cancer screening disparities in women with different types of disabilities. So in women with difficulties performing daily activities, disparities, so this first category is more inclusive of various types of disabilities, the others are more precise. Women with physical disabilities, mental illness, and intellectual disabilities also have lower rates of breast and cervical cancer So any thoughts why this might be the case?
Negative facilities of healthcare?
That could be part of it, yeah.
Maybe this is not directly answering your question, but something involving access to transportation to certain testing sites if you're in a rural area or a very urban area with a bad bus system.
Yeah, that's an issue, especially with women with physical disabilities, but also with mental illness. They sometimes have difficulty accessing transportation.
And I was gonna add, like, even within geography, there's a lot of studies about disparities just based geographically for people who live in like rural areas where the local health clinic just doesn't have the kind of stuff. So I just thought that's something else. In general, but also for people with disabilities.
Yeah, that's a big issue in the general population. For colorectal cancer screening, geography is a big factor. Because in a rural area, you might have to travel quite a ways to get a physician or a surgeon who's specialized enough to conduct the colonoscopies. Or like a few-day follow-up. Yeah, so one recent study which was conducted in Ontario, so it's a Canadian study with a public healthcare system. So you would think there would be no issues since access to healthcare is related to SES, because if you have a higher income, more education, you're more likely to have health insurance. But in a public healthcare system, this should be less of an issue, and yet they still happen. So this study found that women with intellectual disabilities were 79% less likely to get cervical cancer screening tests, and 54% less likely to receive screening mammography. And then other studies, interview and focus group studies, in these studies, women with disabilities sometimes reported that their healthcare professional actually told them that screening isn't necessary for women with disabilities. Now, unfortunately, they didn't explore the reasons why the healthcare professional said that, but this just shows there are some very negative attitudes still in the medical community. So some of the reasons for these disparities. So like I said, if you have a disability, you may have problems working, you may be lower SES. Because of your disability, transportation, or the bias that when you have a disability, you sometimes are viewed differently in the medical community. You might have difficulty accessing healthcare. Women with disabilities are less likely to be married. They may lack social support. They may have difficulties arranging for transportation, and especially for women with physical disabilities, they may have accessibility issues. So, intellectual disabilities are highly stigmatized. I did find a reference that actually says that. But they're highly stigmatized. The only other disability that comes close would be mental illness. So, healthcare professionals may have negative attitudes about people with intellectual disabilities. So these are the two same studies. One study said, participants said breast cancer screening they were told it isn't necessary for women with disabilities. And then a study of family members of women with intellectual disabilities report healthcare professionals told them cervical cancer screening isn't necessary for women with intellectual disabilities.
I cannot believe that.
Yeah, it really happened, and this was a recent study just a couple years ago, so.
So were those researchers able to distinguish between the people who were reporting these experiences having the impression that that's what the physicians were sort of implying, or did they actually verbatim say?
And I think in some cases they showed excerpts of the interviews. They actually, healthcare professionals said no, or what often would happen is the healthcare professionals would assume that their relatives weren't sexually active, so they didn't eat the test instead of like actually asking like, have you ever had a boyfriend? So yeah, it's actually quite shocking, and especially since this is a fairly recent study too. So the rationale for my study, basically I'm hypothesizing that the way healthcare professional attitudes towards individuals with intellectual disabilities and their consequently failure to recommend cancer screening comes from the disparity in cancer screening experienced by individuals with intellectual disabilities. So my research question is, are primary care providers, so family physicians, residents, so family medicine in some studies and in some groups of students or healthcare professionals, they still had negative attitudes. There's also some kind of old research now, but still accurate, in that healthcare providers often lack experience and training in providing care to patients with intellectual disabilities. So traditionally, when people with disabilities were institutionalized, they had specialist physicians who would provide all of their medical care. But starting in the 80s with deinstitutionalization, these people were living in the community, so their family doctor would be the main point of contact for the medical system. But family doctors don't necessarily have a lot of experience with people with intellectual disabilities, and they definitely lack specific training on how to treat people with intellectual disabilities. So, this may come to the question, if you're looking at attitudes, can attitudes really predict behavior? And I say yes, and so does Axon. So, basically, yeah, Axon, he developed this theory in the 70s with fishbane, and it's still used today. I actually, as I'll say in a moment, used it for my master's thesis as well. So basically, Axon proposes that attitude toward the behavior predicts whether someone intends to perform the behavior, and this intention is directly related to whether the behavior actually occurs. The example Axon usually uses is voting intention. If you intend to vote for a candidate, there's a high likelihood you actually will vote for that candidate. There's also subjective norm, which is your opinion of what you think others think about the behavior, and also what type of control you think you have over whether you do the behavior or not. I'm just going to focus on attitudes in this study. So researchers have used this theory to understand health professionals' behavior. So this includes nurses' intention to provide smoking cessation advice, nurses' assessment of pain, clinicians screening cardiac patients for depression, and oncologists and oncology nurses' intention to screen cancer patients for depression. So yeah, that the last publication is from my master's thesis, and partly why I'm showing this slide. Okay, so what do I propose to do in my study? It's got a quantitative portion and a qualitative portion. The quantitative portion, I'll administer standardized questionnaires to measure attitudes towards individuals with intellectual disabilities among primary care providers, and then ask them how do they anticipate, what's the anticipated likelihood that they'll recommend cancer screening to a series of hypothetical patients, both with intellectual disabilities and without. The qualitative portion will involve interviewing family physicians about their experiences recommending cancer screening for patients with intellectual disabilities. So just a refresher for people, the difference between qualitative and quantitative research. Quantitative is what people, especially people in the sciences, will think of as research. Yeah, my background's in neuroscience, so I heard nothing about qualitative methods until I got to my master's. And then I was very fortunate to work with professors and students doing qualitative research. So quantitative methods use numerical data. I once had my undergrad research methods prof said if you can't count something, you can't study it, you can't measure it. Everything needs to be numerical. Then there is also actually a very famous rebuttal that I've heard attributed to Einstein that was actually by a sociologist in the 50s, that not everything that counts can be counted, and not everything that can be counted counts. So you can either measure phenomena if you're doing lab-based research, you'd be measuring things, or in medical research, you can also use surveys, so this would be used more in social sciences research. There's also qualitative methods which gather verbal or textual data, so like written data, either through observation, interviewing, or reviewing written documents. And mixed methods, which is what I'm doing in my study, produce both types of data within the same study. Traditionally, there's been an argument that they use different paradigms, so you should combine methods, but there's since then been some thinking that even if the paradigms are similar just by looking at the same or different types of methods within the same study. So my hypothesis for the quantitative method, or for the quantitative version, is healthcare professionals, students with positive attitudes towards people with intellectual disabilities, as measured by a previously validated questionnaire, will be related to an increased likelihood of recommending breast, cervical, and colorectal cancer screening to individuals with intellectual disabilities. So the method, I'm going to be giving the questionnaire to nurse practitioner students and family medicine residents all across BC. It would be nice if I could do it countrywide, but given the limitations of my PhD, that's unlikely unless my sample size is really low. I may also give the questionnaire to nurse practitioners in the community. Once again, that just depends on response rate. So I'll use a questionnaire to measure attitudes, and then I've also developed a series of 8 vignettes. So there's 4% people with intellectual disabilities, 4 with a chronic illness, and then I ask the students to rate the likelihood they recommend cancer screening to their patients within the vignettes. Yeah.
People lie about this?
Yes, what we do.
Yes, that is a question that actually didn't come up much at my comprehensive, but there is the problem with the attitudes questionnaire. They could get a social desirability bias and give the politically correct answer. A way that other researchers have gone around this is by using a standard measure of social desirability to measure how likely a person is to be influenced by others' opinions. I'm not using it in this study because it would add to the length of questions that the participants have to answer, and also because I realized after my comprehensive, if I included a measure of social desirability, then I would have to write a good 20-30 pages about social desirability and how you measure it in my proposal, and I wasn't willing to do this. So maybe in the future, when I don't have to write a whole dissertation, I'll include that measure, but for now, I'm just sticking with the attitudes measure. To measure attitudes, I'm using the CLAS MR. I used MR because that's how it was published. They acknowledged in the study that it's a very hurtful term, but they found back in the 90s when they pilot tested it, that university students and members of the public weren't necessarily familiar with intellectual disabilities or developmental disabilities, so they chose to use this term, but now I actually was emailing Henry for permission to use their scale, and he asked that I use the term intellectual disabilities. So it's got 40 items scored on a 6-point scale from strongly agree to strongly disagree. And the subscale similarity measures how much you think someone with an intellectual disability is similar to yourself. Empowerment is how much you think people with intellectual disability should be empowered. Exclusion is whether you think people should be socially segregated who have intellectual disabilities. And sheltering is how much you feel people with intellectual disabilities need special protection. So partly why I chose this questionnaire, there were others. Partly it's because this has the best psychometrics. Partly it's because this was the only scale that interviewed people with intellectual disabilities themselves and got their input on how to develop the scale. So this is kind of unusual, and it's because of this reason I chose using this. So for statistical analyses, I'll conduct preliminary analysis, descriptive variables. I'll also see, so past research with attitudes have found age, gender, and previous experience with people with disabilities predict attitudes. So I'll see if they're related. If they are, I'll include that in the final analysis. And then I'll conduct a series of multiple linear regressions to see whether the CLAS subscales has the independent variable and the cancer screening recommendation as the dependent variable. So just a refresher, what does multiple linear regression actually do? So basically it predicts the values of the dependent variable based on variability in 2 or more independent variables. So variability, some is just due to random error whenever you measure something. Other variability may be due to another factor like the dependent variable. So multiple linear regression examines equation in which you can predict the dependent variable based on the values of the independent variables. So for the qualitative study, I, or a research assistant, will interview approximately 10 to 12 experienced family physicians in the greater Vancouver area. The reason for this geographic location is that's where I'm based and we don't have the resources to travel outside. So the 8 vignettes will be presented to the participants in pair. So one with a person with an intellectual disability, one with a chronic illness, and then they'll be asked whether they recommend the type of cancer screening to one participant, both or neither, and why they think that way. And then there's a series of open-ended probing questions that will be asked to help figure out why they answer it that way. So for the qualitative methodology, I will be using thematic content analysis, mostly because my supervisor asked me to. My supervisor, Sally Thurin, developed interpretive description, which is a very complex form of qualitative analysis, which I really struggled with, so I'm doing thematic analysis instead. Unlike a lot of most qualitative research is inductive, so you examine the data within a few terms at a time, so a few phrases or words, and then you build up in the increasing levels of complexity until you develop a theory or an in-depth description. I'm instead going to be using a deductive approach, which is more like the approach used in quantitative research, where I'll be taking this Bronfenbrenner's ecological model and using that to categorize the types of answers that people get. I'll be using open and axial coding that was developed by Strauss and Corbin. So traditional bounded theory, which my supervisor recommends using. But like I said, I won't be getting to the theoretical level. And the goal of the research is to describe the factors related to family physicians' decision to recommend cancer screening to their patients with intellectual disabilities. Yeah.
So the vignettes, like, they have patients with an intellectual disability and without. Could you give like just a basic example of a vignette that you might use?
I have examples at the end of the talk.
Well, the physicist who doesn't know anything about qualitative approaches, what's a thematic content analysis? Could you just give a quick idea of what it is?
Yeah, so it was developed by Newell and Bernard to be more theoretical, since a lot of qualitative research uses like ethnography, which is the study of culture, or phenomenology, which is the study of individual experiences. So the idea with thematic content analysis is it's more positivist. You don't need to buy into complex theoretical paradigms in order to do it. It's more neutral, I guess is the right term. So yeah.
That's sort of like mechanically, I guess I'm asking, what does that involve doing?
Basically, it's most qualitative research has the beginning steps are the same. So you basically pick out a sentence or like a phrase, and then you assign it to a category. And you do that for the entire interview where people are answering open-ended questions. Then you collapse the categories. You read through it again and start collapsing the categories. And you collapse the categories until either with rounded theory, you have an overarching theory, like how people decide to be in cancer clinical trials. Or you have, like in ethnography, a really rich description of a culture or an experience. So it's depending on it's very systematic, and it seems like it's very easy to do, but it's actually very easy to do wrong. So there's been a lot written in qualitative research about how to do qualitative research well. So, some of the limitations for this study. It's a relatively small sample size. It's a restricted geographic area, and it's in a country with a public health care system. There's not the same barriers that are in place in other countries. For the quantitative methods, I'm looking at a single factor, attitudes, and whether that predicts recommendation. As it came up in my comprehensive, what if attitudes don't predict screening recommendation? Another thing that I didn't get a chance to touch on here is attitudes are multifaceted. Some researchers say attitudes are on like a number scale, going from very negative to very positive. Others say they're multidimensional. Yeah? to investigate whether primary care providers would recommend cancer screening to patients with intellectual disabilities. No one knows if primary care providers would recommend the screening, so this is new. No one's ever seen if these attitude questionnaires predict clinical practice like recommending screening, so it's possible that this could be a new area of research to explore further. For other things like family doctors recommending exercise and good nutrition. It will further explore attitudes towards individuals with intellectual disabilities and primary care providers. What was I going to say? Yeah, no one's looked at primary care providers, family doctors, and nurse practitioners. Most studies have been with nursing students, medical students, university students, and other disciplines. So no one's looked at attitudes in this population. And finally, to date, there's only been one study that really interviewed general practitioners about their experiences recommending cancer screening. This study only looked at breast cancer screening too, so it's possible that primary care providers will have different attitudes about cervical and colorectal cancer screening. So these are just a couple of vignettes. I was hoping we'd have time to discuss them in groups, but I think we're out of time. There are the objectives, so hopefully you can define intellectual disabilities now and differentiate it from other disabilities. I touched on the theoretical perspectives behind disability research, and hopefully I convinced you that we need to promote cancer screening among individuals with intellectual disabilities, and ultimately that my research is valuable. So, conclusions. People in this population have low rates of cancer screening. Healthcare professionals may have negative attitudes towards these individuals, and no study to date has looked at whether attitudes predict anticipated likelihood of recommending cancer screening. So I'd just like to acknowledge my committee in closing. Dr. Sally Thorin, who's been with me from day one. Actually, I was thinking, I think it's been about 5 years since I first contacted Sally about doing research with her. Dr. Jennifer Bombush, who's now my co-supervisor. She came on a year or two ago when I had a big shift in my dissertation topic to include intellectual disabilities. And my committee member is Dr. Guy Hislop, who once again has been with me from the beginning of my program, and Dr. Armini Kazajian, who came on at an early stage too after I shifted the focus of my talk, or of my presentation. So thank you very much.